Welcome back to another MDC question style walkthrough. I am Dr. Aiken Skuzi and I'll be taking you through today's session. So as always, we'll be tackling a past question from the MDC Recall Question Bank, and along the way, we'll take an opportunity to revise the topic from which the question was taken. Alright, so let's dive in. Today's question says, a 65-year-old man presents with complaint of blood-stained stools. He has no known comorbidities. A colonoscopy was performed and the image findings are shown below. So this is a colonoscopy image, and the question says, what is the most likely diagnosis based on the symptoms and the image findings? So we have colonic cancer, hemorrhoids, diverticular disease, ulcerative colitis, and rectal prolapse. So let's quickly review the differential diagnosis of bleeding PR or lower GI bleeding, and we'll come back to analyze the colonoscopy image and try to see if we can answer that question. So differential diagnosis of bleeding PR, we can group them into those of inflammatory of origins, and under that category you have diverticular disease, so bleeding from diverticular disease. You have colitis. Under colitis, you can now have inflammatory bowel disease, so inflammatory colitis caused by inflammatory colitis, or even Crohn's disease. Then you have infectious colitis, like dysentery caused by bacterial infection like Shigella or E. coli. These are colitis. These are all colitis. Then you have radiation colitis, especially in patients who are receiving some form of radiation therapy to their pelvic region. So like a patient, cervical cancer patient receiving some form of radiation therapy, or a prostatic CA patient receiving some form of radiation therapy. These patients can develop radiation injuries to their colon and can present with bleeding PR. So these are from radiation colitis, but these are all under the umbrella of colitis, inflammation of the colon. Then you have proctitis, which is inflammation of the rectum. These typically result from STIs, especially gonorrhea and syphilis, and as well as herpes. And so these condition, especially you see in patients who are engaged in anal sex, so men who have sex with other men, and heterosexual couples who engage in oral sex as well can also have or develop proctitis, and that can present with bleeding per rectum. So these are some of the conditions under the inflammatory origins that can present with bleeding PR, so bleeding per rectum. You can also have ulcers, so rectal ulcers, and really stachoral ulcers. These are ulcers that arise from patients with impacted stools in the rectum. So typically you see them in elderly bedridden patients, or patients who are generally bedridden might end up having impacted stools in their rectum, and that can lead to the development of stachoral ulcers that can bleed. Then you have bleeding PR from vascular origin. So you have hemorrhoids, you have intestinal ischemia, so ischemic colitis. These are vascular conditions. Acute mesenteric ischemia, so any blockage of the blood vessels to the intestines can lead to ischemia of the bowel, and that can bleed, and so the ischemic part can now ulcerate and bleed. You have atriovenous malformations, can also lead to bleeding. Under these vascular malformation, you might hear of a condition called dural voice, but these are not very common. These are really rare conditions that can also bleed and present with bleeding PR. Then you have varices, so colorectal varices. Just as you have esophageal varices, you can also have varices occurring in the colon and the rectum, and these can also bleed. Other ones such as tumors, so you have another category of tumors. You have colorectal cancers, so that's another big category on its own, which can also present with bleeding PR. Then you have anal cancers, so colorectal and anal cancers, these are under the tumor categories that can present with bleeding PR. Then you have colonic polyps. These are benign lesions, but they are also tumors that can present with bleeding. Typically not, they don't typically present with bleeding, but especially when you go in and you do surgery, for instance, do a polypectomy, it might now end up having bleeding from the side of the surgery. But the common ones under the tumors are the colorectal cancer and the anal cancers. Then you have other lesions that can also present with bleeding PR. You have anal fissures. These present with pain as well. Then you have Merkel diverticulums. These are typically common in the pediatric age group. Then you have bleeding disorders. So coagulopathies in general can also present with bleeding PR. But this is just a brief overview of differential diagnosis of bleeding PR. We have a dedicated module where we go into details on some of these conditions that can cause bleeding PR. So make sure to check those models and learn more on these conditions. Now let's get back to the question and look at the colonoscopy image and see if we can narrow down the differential diagnosis of the patient in question. So the questions once again sets a 65-year-old man. So let's try and try and map out some relevant information here. So 65-year-old, this is generally an elderly patient. You consider this patient as elderly. And then they complain of blood stains too. So there's lower bleeding PR. So there you go. And we are told that there are no other comorbidities. So nothing else relevant here, apart from the fact that he's aged and he has blood in his stools. And these are the differential diagnoses that we've been given in our question. These are the possible options that we've been given. So let's try to see if any of these can cause bleeding PR, as we've just discussed in the previous slide. So colonic CA, as we mentioned, can cause bleeding PR. You have hemorrhoid, can also cause bleeding PR. Diverticular disease can also cause bleeding PR. Ulcerative colitis, this forms under the inflammatory condition. So colitis can also cause the bleeding PR. Rectal prolapse, not so much. So rectal prolapse typically doesn't cause bleeding PR, but in the case where you have chronic prolapse, the mucosa, the rectal mucosa can now become edematous and be prone to ulceration and subsequent bleeding. So yeah, I mean, when you are pushed to the wall and you're mentioning differential diagnosis for bleeding PR, of course you can mention that, but typically rectal prolapse does not present with bleeding PR. Now let's look at the colonoscopy image. So this is the image that I've been given. This is an endoscopic image view of the colon, and we can see these are the rugae. So let me use arrow here. So you have, these are the rugae that you see typically in your colon, but then you have this fenestration here, or it's like a hole that is burrowing into the mucosa of the colon, and you have one down here too as well, and then there are few ones here too down there as you go down. So there are multiple of these grooves or burrows that are burrowing into the mucosa. So they are more like fenestrations into the mucosa. Now when you look at the same patient on the barium enema, so this is a double contrast enema of the same patient, you will see that you have these multiple out pouches on the skin as well, and on the mucosa of the colon as well. So there you have these green overlays showing you the multiple out pouches in the colonic mucosa. So if you now have these multiple out pouches on the mucosa of a patient, the person is an elderly, and you have bleeding PR, you put all of these things together, and you are, and you go through these differential diagnoses being given as the options, you come down to a more likely diagnosis here to be diverticular disease. So you put everything together, patient symptoms, which you said is bleeding PR, so blood stained stools, and the fact that this patient is an elderly patient, is aged, and the colonoscopy findings that we've just seen, the most likely diagnosis is a diverticular disease. Now, in some instances, when you find this question as a written OSCE, you might be asked some follow-up questions aside just making the diagnosis. But of course, the follow-up questions, getting the follow-up questions right, depends on making the right diagnosis. So that's where we spend a lot of time trying to establish that diagnosis. Now, once you establish the diagnosis, the follow-up questions, you should be able to answer those. And so let's see some of the possible follow-up questions that you could be asked. So follow-up questions like risk factors. So now we are now talking about risk factors for diverticulosis. Now, diverticulosis, you have diverticular disease, which is a big umbrella, which consists of both diverticulosis and diverticulitis. So diverticulosis is just multiple outpouches of the colonic mucosa, and that is what we're seeing in the colonic in the colonoscopy, and both in the colonoscopy and the barium enema. So that's diverticulosis. So some of the risk factors. Briefly, to understand how diverticulosis come about, let's just talk about how it comes about in terms of the pathophysiology. And so typically, before you have the outpouches of the mucosa happening, there must have been some form of increased intraluminal pressure. So there's a chronic increase of intraluminal pressure within the colon, and this typically results from constipation. And so once we know that chronic constipation can now lead to a chronic elevation of the intraluminal pressure, then when you're talking about risk factors, you're looking at things, conditions that can increase your risk of developing constipation. Then you also have age-related weakening of the connective tissue. So even though the mucosa, there needs to be an increased intraluminal pressure, there are supportive connective tissues that prevent the mucosa from outpouching or from bulging out. But in an aged patient where you have weakening of the mucosa, of the connective tissue, especially the muscles of the intestinal muscles, you can now have this mucosas outpouching, and that leads to the diverticulosis. Also, physiologically, in the colon, you don't have a circumferential distribution of the muscles. So yeah, you have these muscles in some areas that are bind together longitudinally, and that's why you end up having these hostrations and things in the colon. So there are some physiological gaps within the muscle wall of the intestines. So you have your tinea coli, and then you have these bind together areas leading to your hostration. So there are physiological gaps within the muscular wall of the intestines, and so coupled with an increase in intraluminal pressure, you can now have outpouching of the mucosa and leading to the formation of diverticulitis. So now, having revised that pathophysiology, you can now begin to imagine some of the risk factors. So diet is one of the main risk factors. So diet that are low in fibers would typically predispose you to having constipation, because the more fiber you have in your diet, you have more fiber in the stool, ending up in the stool, that will help absorb water and soften the stool so that you don't get constipated. So diet that are low in fiber or predispose you to developing constipation and subsequent increased intraluminal pressure. They have obesity, low physical activity, also an increased risk of developing constipation as well. Increasing age will lead to weakening of connective tissues, and smoking generally, can also cause weakening of the connective tissue of the intestinal wall. Then you have other risk factors such as genetic conditions that causes weakening of connective tissues. So you're looking at Marfan syndrome, which can lead to weakening of connective tissues. You have Ehlers-Danlos syndrome, which is one of those conditions, so that can cause weakening of connective tissues. And so these are some of the risk factors that can predispose you to developing constipation. And so talking about diet especially is one of the reasons why diverticular disease tends to be more common in the Caucasians or in the Western world than in the developing part of the in our part of the world, which where our diet mostly constitute very high tend to have very high amount of fiber in it. Right. So another follow-up question that you could be asked is complications that could arise, and of course we've already seen one of the complication here, so they won't expect you to be mentioning the complication that you've just seen in the question. The complication here is bleeding PR. So if you're mentioning complications, you don't have to mention, you can't mention bleeding again. So that's why I've omitted that here. So the question would typically be, what other complications can this patient have aside the bleeding PR, which we've just discussed? So aside the bleeding PR, which is one of the common complications, and making diverticular disease one of the commonest cause of bleeding PR. Aside that, you have acute inflammation of the diverticulitis. So you can have acute inflammation, which is diverticulitis. Now, with diverticulitis, you can have subsequent complications from the inflammation of the diverticula. So, perforations, so GI perforations. You can have fistula formation. So you have a fistula formation between the colon and then the bladder, for instance, when you have a proximity of a diverticula between the colon and the bladder. So you have bladder and the colon fistula formation because of the complications of the of the of the diverticulitis. Then you can have abscess formation as well. So these are all possible complications that can arise from acute inflammation of the diverticula. Then you have chronic inflammation of the diverticula. So it inflames, resolves, inflames, and resolves. So you now have this chronic inflammatory condition going on. And these symptoms sometimes tend to mimic what you see in patients with inflammatory bowel disease, such as Crohn's disease. Right. So, this is just a general overview of this condition, but we have a whole dedicated model on going into details on diverticular disease. Now, one last question that you could be asked is, how do you diagnose this patient? So definitive diagnosis, of course, we always say that, in medicine, diagnosis of the patient depends on the patient history, clinical examination, and of course, your investigations. You have supportive investigations and you have diagnostic investigations. But a definitive diagnosis for a patient who you suspect to have diverticular disease is colonoscopy. Now, you don't go around investigating every patient. Most patients with diverticular disease are asymptomatic. So the ones who come to you requiring investigations are typically the ones who are symptomatic. So symptomatic investigation of symptomatic diverticular disease is colonoscopy. That's a diagnostic management. It used to be the double enema, double contrast barium enema, which used to be the diagnosis of choice, but that has changed over the years because colonoscopy has now become more common now, and it has the other advantage of allowing you to biopsy lesions when you see them, and also secure hemostasis in cases when the patient is bleeding massively. So definitely diagnosis colonoscopy. All right, so I hope that was helpful, and catch you next time on our next session. All right.